Hey everyone, my name is Garrett. This is going to be the final for EMS Instructor Methodology. This is just going to be a quick, about 45-minute overview on pharmacology at the EMT level. So we'll go ahead and jump in. A little bit about me before we get started. I've been an EMT since 2022, so it'll be, let's see, I guess that'll be 3 years in March. So, yeah, about 3 years. I was in paramedic school, but I had some unfortunate circumstances. I had to have knee surgery, so that took me off the truck. So I'm taking this class to hopefully teach the next generation of EMTs. So let's get into the lesson here. Just a quick intro. What is pharmacology? So pharmacology is the study of how drugs and chemicals affect living organisms. So for us, that's just going to be really drugs. We're not going to be given any chemicals. It's just going to be drugs. So the study of how drugs affect our patients. So that's going to be the biggest thing there. And why is pharmacology important? Why do we care? So we want to learn about pharmacology. We want to make sure we're giving our patients the proper medications and treatment. We want to make sure that our patients are going to get the right medication and we're not just giving out medication all over the place. And we want to make sure that our patients are getting proper treatment. A couple key terms that are important to know. A lot of people do like to get these confused, but they are two completely different things. So pharmacokinetics is the movement of drugs into, through, and out the body. So that's just going to be how a drug moves through the body from the moment it gets put in there. So whether you take it by mouth or it goes in an IV, and then it comes however long it takes to come out of the body and just be gone completely. And then pharmacodynamics is the study of biochemical, physiologic, and molecular effects of drugs on the body. I know that that definition is kind of big and scary, but to break it down a little bit, it's really just going to be the study of the effects of drugs on the body. That's really the base of that definition. I know those three words are kind of big and scary, but the study of the effects of drugs on the body. Here's a nice little chart here for all my visual learners. So pharmacokinetics is going to be what does the body do to the drug. Oops, sorry about that. And there's a nice little mnemonic here. Absorption, distribution, metabolism, and excretion. So that's going to be from the moment you take it all the way until it's gone out of the body, however long that may take. And then over here for pharmacodynamics, what does the drug do to the organism? So what does the drug do to the body? And then over here we've got what does the body do to the drug? So the effect, whether that be desirable or undesirable, hopefully we're getting the desirable effect, but undesirable effects do happen. We'll talk about that a little bit later. But yeah, those are both, this is a really good chart to understand the difference between the two. And then in the middle here, they both worry about drug concentrations and effect. So just a few drug classes. There's tons more than this, but these are, I feel like, are the three most important ones, at least at the EMT level. So analgesics, those are going to relieve pain. That's going to be something like a Tylenol that we can give, something to just hopefully relieve that patient of a little bit of pain. Antihistamines, this is going to be something like a Benadryl that we can give. That's going to block the effects of histamines. So block histamines, antihistamines. That one's pretty easy to remember. And then cardiovascular, obviously that's going to treat the heart and vascular illnesses. So another easy one to remember there, cardiovascular. So really the only one that's kind of difficult to learn is the analgesics, because that one, the name for that one doesn't really make sense like the other two do. So some routes we can give drugs. A few of these are not really going to be used that much, and then a couple of them are not going to be used by you at all at the EMT level. So oral, that's going to be when we take a medication by mouth. I'm sure everyone in here takes a medication orally, maybe every day, if not every day, once a week. Sublingual, that's when something is just going to get placed under the tongue, and then it's going to dissolve and go into the body that way. Inhalation, that's when something is just going to be inhaled. A lot of these are easy to remember, but inhalation, it's going to be when something gets inhaled. Intravenous, that one don't really need to worry about at the EMT level, but it's still good to know. That's when something is going to go in through the vein, through a catheter that's placed into the vein. Intramuscular, that's when a needle is going to go into the muscle. It's going to penetrate the skin and go all the way down into the muscle, and the medication is going to get delivered through that muscle. Intranasal, that's going to be through the nose, so something's going to get sprayed up the nose, and the medication is going to go through the body that way. Subcutaneous, not really used that much at the EMT level. I've seen it done, but not very often. That's when something's going to go into the subcutaneous fat layer. And I've got a diagram on the next slide for those of you that may not quite know what that means. And then intraosseous, again, not going to worry about that one at the EMT level, but it's still good to know. That's when a paramedic drills into the bone and the medication gets delivered through the bone. Here's that diagram I was talking about. It is very blurry on my end. Sorry about that, but I'll do my best to explain it. So intramuscular, that's when the needle's going to be at a 90-degree angle, so straight up and down. And that's going to penetrate all these layers, the epidermis, dermis, and subcutaneous tissue. And it's going to go into that muscle. And then subcutaneous, like we were talking about, that's going to be at a 45-degree angle, so not quite straight up and down. That's going to penetrate the dermis, the epidermis, and it's going to go into that subcutaneous layer. And then intradermal, it's not really used in EMS, but if you've ever had a TB test, which I'm sure a lot of you have, this is what they use for that, and then it kind of bubbles up in the skin. But that's going to be about a 10-degree angle, so almost straight on with the skin, and it's going to go straight into the epidermis. That's when it kind of bubbles up right there into the skin. So all these routes have different times. They're not absorbed by the body at the same rate. So the quickest is going to be the two that I told you not to worry about. It's going to be intravenous and intraosseous. Those two are going to be absorbed by the body almost instantly. Again, not going to worry about those two, but it's still good information to know. Endotracheal, again, another one you're not going to worry about. That is when a patient is intubated and you drop the medication down the endotracheal tube. Not going to worry about that, but still good to know. That's going to take about 2 to 3 minutes. Inhalation, also going to take about 2 to 3 minutes. Sublingual, again, that's when medication is placed under the tongue. That's going to take about 3 to 5 minutes. Intramuscular, as we can see in this chart back here, that's when it goes into the muscle. It's going to take about 10 to 20 minutes. And then subcutaneous, when it goes into this fat layer here at a 45-degree angle, that's going to take about 15 to 30 minutes. Rectal, not really going to worry about it at the EMT level or in EMS, really. But it is good to know if a patient has taken a medication rectally, how quickly you're going to see those effects. That's going to take about 5 to 30 minutes. So that one's kind of a broad spread there of how long it can take. Same with ingestion. That's going to take about 30 to 90 minutes. So that's going to be when we give something PO. You might not even see the effects while you're transporting that patient of a PO med. Transdermal, that one is not really used that much. I have seen like nitroglycerin paste that gets used, and that one really varies minutes to hours. So that's probably why it's not really used that often. So the 6 rights, these are really important. This is going to make sure that the medication is given correctly and everything is being done the way it should be. So for the 6 rights, we want to make sure we've got the right patient. That's really not much of an issue in EMS as much as it is in, we'll say, nursing, where you've got multiple patients. I guess if you're at like an MCI or something, it could become an issue. But it's still important to make sure that you're giving the right patient the medication. You don't want to be giving a different patient a different medication just for no reason. The right drug, obviously we want to make sure we're giving the patient the right drug. We want to make sure we're cross-checking with our partner. Make sure that we're reading the label on the bottle. Make sure that we're giving the right medication. Right dose, again, we want to cross-check with our partner. If there is math involved, you want to make sure that your math's right. Double check, triple check. Make sure all that math is correct so the patient's getting the right amount of the medication, because if you give them too little, it's probably not going to work, and if you give them too much, you might have some adverse effects you might have to worry about. The right route, you want to make sure that you're giving this patient the medication through the right route. You want to make sure that it's getting into their body efficiently and as quickly as possible. So if you can give something IM, I would recommend giving an IM. But some patients may not want that, and you can just give it to them orally, and that works too. Right time. You want to make sure that this medication is being given at the right time. So you want to make sure that you've done everything you need to do before giving this medication. And we'll talk about getting a history and stuff later. But you want to make sure you want to make sure all your boxes are checked before you give them medication. And then write documentation. We'll talk about documentation too a little bit later, but documentation is super important, because if you didn't document it, then it didn't happen. So you want to make sure that in your chart, you want to make sure that everything is correct, whether it be the time the medication was given, the dose, what medication. You want to make sure all that is correct. Here's a nice little mnemonic for the 6 rights. I know some of you are visual learners, and this chart will help a lot. So the mnemonic's going to be patients do drugs round the day. So PDDRTD. So right patient, right drug, right dose, right route, right time, right documentation. So patients do drugs round the day. So that's a good way to remember those 6 rights. So what can we give? We've got a nice little list here of all the medications that we can give at the EMT level. So we're going to give acetaminophen, and we'll talk about all these drugs in more detail coming up. But we've got acetaminophen, Afrin, albuterol, aspirin, charcoal. That one's not really used anymore, but it's still good to know. Diphenhydramine, epinephrine, ibuprofen, oral glucose, oxygen, naloxone, and nitroglycerin. I know that list is maybe a little daunting, but we're going to get into these in detail, and hopefully it'll be easy to remember once we see what everything does in detail. So we'll jump into that here. We'll start with acetaminophen. I'm sure many of you have taken acetaminophen, maybe even today. Most people are going to know this as Tylenol. The adult dose is going to be 1,000 milligrams, so that's going to be given orally. In the pediatric dose, there's going to be some math involved, so it's important to make sure that you know the patient's weight, if it is a pediatric, or if it's impossible for you to get the patient's weight, the Brasillo tape is a good resource to use, and we'll talk about that a little bit later too. But usually if mom or dad is there, they'll know the weight of the patient, especially if they're younger. So that's going to be 15 milligrams per kilogram. So for every kilogram the patient weighs, you're going to give them 15 milligrams of acetaminophen. Indications for this are going to be pain and fever. So if a patient is having a little bit of pain, I wouldn't necessarily use it if the patient is in severe 10 out of 10 pain, because it's not really going to do anything for them. They might get a little mad at you too if you offer, we'll say, a gunshot wound patient Tylenol. It might not be a good look. And fever. If the patient's got a fever, give them some Tylenol. Hopefully bring that fever down. And again, this is going to be taken orally, so if you're transporting this patient, you might not even see those effects. The hospital hopefully will, but you might not even get to see them. And then contraindications for this, you want to avoid in patients with severe liver disease. So if a patient tells you, hey, I've got liver disease or liver failure, probably want to steer clear of Tylenol, and we'll try something different. Next one here is going to be Afrin. Again, a lot of you probably know about this one. Not really used that commonly in EMS. I personally have never seen it used. But the adult dose is going to be 2 sprays in the affected nostril. So this is just like any other nasal spray, like a saline or something. Except it's got medication in it, unlike saline. And then the pediatric dose is going to be 1 to 2 sprays. So you can do 2 sprays, but if it's a little kid, you might want to bump it down to 1 spray. For this, nasal intubation, if a paramedic is getting ready to perform a nasal intubation, we might want to give Afrin. It's going to close those not close, but it's going to tighten those blood vessels up so that not as much blood is getting through. Same thing with epistaxis, that's nosebleed. It's going to hopefully constrict those blood vessels so that the bleeding can be controlled a little bit easier. And then contraindications for this are severe hypertension. If a patient has really high blood pressure, the last thing we want to do is constrict their blood vessels even more, because that's just going to raise their blood pressure even more. So if they've got severe hypertension, you probably just want to stay clear of this. and try something else. Albuterol. Again, a lot of you probably know what this is. This is what's commonly in your prescription inhalers that many of you might carry. The adult dose is going to be 2.5 to 5 milligrams in a nebulizer. And they're going to take that continuously. So the patient is just going to hold that nebulizer up to their mouth and they're just going to breathe that in. And you can do that up to 3 times. So if you do it the first time, I would listen to lung sounds again. If you still hear wheezing, I would give them another one. If the wheezing has stopped, I would just cut it right there. There's no need to give a patient an unnecessary amount of medication. We don't want to over-treat. And the pediatric dose is just going to be 2.5 milligrams, so you're not going to have that range. And that's also going to go in a nebulizer, and again, up to 3 doses. And again, if you listen to lung sounds and the wheezing has stopped, cut it right there. No need to give all 3 of your doses. Indications, respiratory distress with bronchospasm. So the way you're going to know if it's bronchospasm is going to be wheezing. If you hear wheezing in the lungs, that's bronchospasm. So if you hear wheezing, you're immediately going to turn to albuterol. And again, this is in a lot of patients, like prescription inhalers that some people may carry, and some people may just need help administering their inhaler. So that takes out the math for you with having to calculate everything. And a lot of the albuterol is prepackaged anyway, so it takes out the math anyway. But some patients may just need help administering their inhaler, so you won't have to go through all this trouble of setting up the nebulizer and everything. Aspirin. Once again, another one that a lot of you have probably heard of. The adult dose is going to be 4 81 milligram chewable tablets. So if the tablet is an 81 milligram tablet, you're going to give them 4 of those, and that's going to equal 324 milligrams. I have seen aspirin that is packaged in 1 tablet that's 325 milligrams. That works too. That's even easier instead of making them chew up 4 tablets. I think it just probably depends on the supplier your agency uses and where you guys are getting them from. But I have seen them packaged as 1 pill. Not indicated, so pediatrics aren't going to get this. If a pediatric patient is having chest pain, it's more than likely not going to be cardiac related, so we're not going to give them aspirin. And then indications for this, if a patient's having chest pain, we're going to want to get this in pretty quickly, unless they have some kind of allergy to it, obviously. But it's an antiplatelet drug, so it hopefully helps to make sure that clot in the heart isn't getting any bigger than it already is. So that's why we want to get this on pretty quickly for a chest pain patient. Charcoal. So this one is not really used commonly. Again, I've never seen it used just because it's kind of a pain to get set up, because a lot of them come packaged in a powder, and then you have to mix that and give it to the patient, and it doesn't taste great either. So it's not really commonly used, but it's still good to know the doses and what it does. So the adult dose and the pediatric dose are going to be the same here, so 1 gram per kilogram. So again, for pediatrics, if you don't know the weight, the Broselow tape's a good resource. A lot of adults will know their weight, so you can do the math on that one. With every kilogram they weigh, you're going to want to give 1 gram, so it's 1 to 1. So if the patient weighs 100 kilograms, we're going to give them 100 grams of charcoal. Indications are going to be non-narcotic overdose. So this is going to be when a patient takes a medication that's not a narcotic. We're going to want to go ahead and give them charcoal. If your agency even carries it, I know mine doesn't. But again, still good to know. If it is a narcotic overdose, we'll give them a different medication, and we will talk about that a little bit later. So this is going to help to prevent the poison from being absorbed by the body. So again, still good to know, but not really used that commonly. Diphenhydramine. So a lot of you probably know this as Benadryl. You might take it when you're sick, take it when you've got some kind of allergic reaction, or maybe even just take it to go to sleep. I don't know. But the adult dose for this is going to be 25 to 50 milligrams, and you can give this pretty much just about every way. So you can give it IO, IV, IM, or PO. Most of the time at the EMT level, we're going to give it PO. That's just going to be the easiest thing to do. And then paramedics can give it IV or IO if they need to. Pediatric dose is going to be 1 milligram per kilogram. So again, if the patient weighs 50 kilograms, we're going to give them 1 milligram of, I'm sorry, if the patient weighs 50 kilograms, we're going to give them 50 milligrams of the medication. Sorry about that. And again, you can give this just about every which way, but at the EMT level, we're really only going to focus on PO here. Indications for this, it's going to be an antihistamine. So going back to our drug classes earlier, antihistamines, antihistamine, they block histamines from coming into the body. This is going to help to control an allergic reaction a little bit better. Epinephrine. So this one is going to be used in anaphylaxis. A lot of people may know it as coming in an EpiPen. And we'll talk about that a little bit later. Actually, I think it's the next slide. The adult dose for this is going to be 0.3 milligrams. That's going to go into the muscle at the EMT level. At the paramedic level, it can be given IV, but we're only going to worry about IM here. The pediatric dose is going to be 0.01 milligrams per kilogram IM. Max dose of 0.3. So if the patient weighs a certain amount that's going to get them to 0.3, we're just going to give them the adult dose. Indications for this are going to be anaphylaxis. It's a vasopressor, so it's going to hopefully constrict those blood vessels a little bit. And we're going to give this for an anaphylactic reaction. So this is how a lot of you may know epinephrine as an EpiPen, but it does come in vials too, where you have to draw it up. But sometimes a patient, especially if they know they have an allergy, they're going to carry their own EpiPen around with them. So you might just need to help them administer this instead of having to go through the trouble of drawing up your medication. So this blue cap's going to pop off. That's kind of like a safety. That'll just pop off. This orange end is going to go towards the patient's thigh. So I talked about this a little bit in my last lesson about shock, but this is not a button. Do not press this down because the needle is in here. So if you press this with your thumb, the needle's going to come out right there and it's going to go into your thumb. And then you're going to have epinephrine in you, and that's not going to be a good day. But again, blue cap comes off. This end goes to the patient's thigh. You just press that down into the patient's thigh, and you hold it for, I believe it's 10 seconds. Hold it there for 10 seconds, and then that's it. That's all you got to do. So these are really dummy-proof. The directions are even right there on the packaging. Some of the newer EpiPens will even talk to you, tell you exactly what to do. So really, really easy to use, and such a lifesaver compared to having to take the time to get the vial out and get the needle and draw up the medication. Ibuprofen, so another really common one. A lot of people are going to know this as Motrin or Advil. Again, probably one that you've taken before, maybe even today. The adult dose for this is going to be 400 to 800 milligrams. That's going to be given orally. The pediatric dose is going to be 10 milligrams per kilogram. So if the patient weighs 50 kilograms, they're going to get 500 milligrams of the medication. If the patient is 6 months old or younger, we're not going to use ibuprofen. We're going to avoid that. Probably go with Tylenol in that situation. Indications for this is going to be used for pain and fever, same as Tylenol. This is an NSAID though. This is a non-steroidal anti-inflammatory drug. So it's going to hopefully reduce inflammation, but it's not a steroid. So it's a little bit easier to get a hold of and a little bit easier to use. Contraindications for this: pregnancy. If the patient's pregnant, can't give them ibuprofen. History of GI bleeds. Again, if the patient tells you, hey, I've get GI bleeds pretty commonly, or hey, I had a GI bleed 2 weeks ago, we're going to want to steer clear of ibuprofen, and probably we'll go with Tylenol in that situation. And if a patient is taking blood thinners, we're not going to want to give them ibuprofen either. So if a patient tells you, if you go through your sample history and you get medications and they say, oh, I'm on warfarin or something, another blood thinner, probably going to want to steer clear of ibuprofen. Oral glucose. So this one is pretty commonly used. Nice, easy medication to use for hypoglycemic patients. The adult dose and the pediatric dose are going to be the same thing. It's just going to be one of the little tubes or packets, whichever your agency carries. And you can repeat it as needed, but let's stress that you need to check the patient's blood sugar after giving one tube. You don't want to just keep feeding tubes to them. I would check it again after one tube. If it's good, stop. If it's still low, give them another one, then check again. We just don't want to go raising the patient's blood sugar like crazy, because then we're going to turn a hypoglycemic event into a hyperglycemic event, and it's not going to be a fun day. So again, as I was saying, indications: hypoglycemia. If a patient's blood sugar is low, they're more than likely going to get oral glucose. And the contraindications for this are an unconscious patient or a patient that can't swallow. So if a patient's unconscious, we're not going to be going and opening their mouth and giving them oral glucose that way. If they can't swallow, we're also not going to be forcing oral glucose down their throat. If a patient is having a hypoglycemic event and they are unconscious, that's going to be something to worry about at the paramedic level, where a paramedic can give sugar IV. So we don't want to go shoving oral glucose down a patient's throat when they're unconscious. Oxygen. So this one is going to be the most common one you'll see. Probably use it every day of your career. It's a great tool, but a lot of people do like to overuse it. So the dosing going to be the same for adults and pediatrics. So through a nasal cannula, and I've got pictures of all these on the next slide for those of you that may not know what those are. It's going to be 1 to 4 liters per minute via nasal cannula. And then through a non-rebreather mask, it's going to be 6 to 15 liters per minute. So that's going to be more your high flow oxygen. And then if you're using a bag valve mask trying to breathe for a patient, it's always a good idea to hook it up to oxygen. That's going to be running at 15 liters per minute. Indications for this are going to be respiratory distress, increased cardiac workload. If a patient's heart is working really hard, they're going to be breathing heavy, trying to take in more oxygen, so we're going to give them some oxygen to try and help out with that. And then poor ventilation or perfusion. The goal of oxygen is to get to 94 to 99% on the monitor when it comes to oxygen saturation. The reason we don't want to get to over 99%, 100%, because there are some studies that show that too much oxygen can be a bad thing, and the monitor only goes to 100%. It's not going to show you if you're at like 110%. So it's always a good idea to try and stay below 100%. So if they are at 100%, probably a good idea to take the oxygen off. Here's those pictures I was talking about. So this is a nasal cannula. This end here is going to get hooked into the oxygen tank, and it's got all this tubing. And then this part is going to sit on the patient's face. This part's going to go into the patient's nose. These two prongs are going to go into the nostrils, and they're going to breathe in the oxygen through those two prongs. So if a patient is using a nasal cannula, it's always a good idea to make sure they're breathing through their nose and not through their mouth. If they're breathing through their mouth, they're not going to be getting any of this oxygen. If they are breathing really fast and breathing through their mouth only, and they just can't breathe through their nose, this might be a good idea. This is a non-rebreather mask. So this mask is just going to go over the patient's face. This metal piece right here will clamp over the patient's nose, kind of like a surgical mask where it has that wire that you can clamp over the patient's nose to get a better seal. This is just going to have them breathe nothing but straight oxygen. So they're going to be breathing straight oxygen. This is, again, going to be good for your high-flow oxygen patients. And then it's got tubing that goes for however long you want it to go. You can add attachments to it, but the end is going to look similar to this, where you can just hook that into the oxygen tank. And then down here, this is a bag valve mask. So if a patient is not breathing at all, or breathing like, we'll say 2 or 3 times a minute very slowly, we're going to want to breathe for them with this. So again, tubing. This tubing is going to get hooked into the oxygen tank. The piece looks just like this. This mask is going to go over the patient's face, over their nose and mouth. We want to make sure we got a good seal on that so none of this good air is escaping that. And then this bag here, that's what you're going to squeeze to breathe for the patient. You're going to squeeze that once every 6 seconds to breathe for the patient. Naloxone. So this one is kind of a hot topic these days. It's been in the news. It's everywhere. You can get it at drugstores now. Definitely something that gets talked about a lot more than it used to. This is going to be known as Narcan more commonly. So the adult dose for this, 0.4 to 2 milligrams. You can give this IV, you can give it IO, IM, or IN intranasally. That's going to be most common. I've never seen it given in these other ways, but intranasally is going to be the most common. And when it comes to giving it intranasally, it's prepackaged most of the time. There's no need to do math or anything. Pediatric dose, 0.1 milligrams per kilogram. So again, there's going to be some math involved, but the Broselow tape is a good resource for you. And again, you can give this IV, IO, IM, but I've only seen it given IN intranasally. That's going to be the most common, as I say down here. Indications for this are going to be narcotic overdose. So if a patient has overdosed and you know they've taken a narcotic, it's a good idea to go ahead and give them Narcan. Now with Narcan, I will say this. You want to give it kind of slowly, because if you go in and slam Narcan to a patient, like a lot of police officers and firefighters tend to do, slamming Narcan is going to wake that patient up really quickly and really aggressively, and a lot of times that patient will come up, sometimes they'll come up swinging. It won't be, you'll have to restrain that patient more than likely, because they're going to be mad that you just ruined their high. So it's a good idea to kind of just push it slowly. You don't want to go in and slam it, and we can see in this picture here, you don't want to go ahead and just slam that down. I would just push it nice and at a nice steady pace. This is what a lot of Narcan looks like now. It's prepackaged, just one spray in each, so once this is done, it's done. Throw it away. This nozzle here is going to go into the patient's nostril. Again, it's like any other nasal saline spray, or even like Afrin, like we talked about earlier. This is the plunger, so that's the button you're going to push once that's in the nostril, and the medication is just going to get sprayed out through the top of this hole here. Do not test the spray. It's only got one spray in it, so don't go and test it like you might do with saline spray or Afrin. Like I just said, it's got one dose, so once you push that plunger, you're done. Throw it away. And sprays one time only. So nitroglycerin is going to be the next one. This one is pretty commonly used in EMS. A lot of patients will even have their own nitroglycerin prescription that they might need help taking. The adult dose for this is going to be 0.3 to 0.4 sublingual, so we're going to give this under the tongue. And the 0.3 and 0.4, it really just depends on how it's packaged. It comes a couple different ways, and we'll talk about that in the next slide. And you want to give that every 5 minutes until their pain subsides. So in 5 minutes, you want to ask them, rate their pain on a scale of 1 to 10. If it's gone down, awesome, that's enough nitro. If it's still there or even going up, you might want to give them a little bit more. Pediatric patients, again, if a pediatric patient is having chest pain, it's more than likely not cardiac related, so we're not going to give them nitro. Indications for this, chest pain, like I was saying, contraindications. So this one's going you got to be careful with. So hypotension, if the patient's systolic blood pressure is lower than 100, we're not going to give them nitro. So nitro is going to, the way it works is it dilates the blood vessels. So if their blood pressure is already low and then we go and dilate their blood vessels, that's going to drop their blood pressure even more. And we don't want that. And then if the patient recently took any medications for erectile dysfunction, so before you give this medication, excuse me, it's always a good idea to ask if the patient took anything for erectile dysfunction, because the way erectile dysfunction medications work is they also dilate the blood vessels. So if their blood vessels are already dilated, and then we give them another medication on top of that, that also dilates their blood vessels are going to be super dilated, and they're going to have a terrible blood pressure. So we don't want that, obviously. So we want to make sure we're asking these patients what they've taken, if they've taken anything, and we also want to make sure we're getting a good set of vitals before we give medication. So as I was saying, it comes packaged a couple different ways. This is nitro spray, so this is also going to go under the tongue. They're both going to go under the tongue, but this is just going to be one quick spray under the tongue, nice and easy. These are the nitro tablets. These are going to go under the tongue and they dissolve. This is what a lot of patients who have prescriptions will have, and they might just need help with this. But those just go under the tongue. It also comes packaged in a paste. I have not seen that as commonly, but it comes in a paste. You put it on like a little piece of paper, and then you stick that to their skin, and it gets absorbed that way. But these two, I would say, are the most common. So that's it for the medications. So now we're going to talk about side effects and adverse reactions. So a lot of people like to group these together as the same thing, but they are two very different things. So a side effect is an effect of a drug that is in addition to or beyond its desired effect, and it can be harmful or it could be beneficial. And most side effects are going to just go away on their own. You don't need to worry about them. Side effects are pretty common. I'm sure a lot of you have taken medications and experienced some kind of side effect with it. So those are pretty common. Adverse reactions, however, are not common. And if an adverse reaction is happening, then we're going to be worrying about a completely different situation. So that's an undesired harmful effect. So notice that these can be beneficial. These are all harmful. This is resulting from a medication. And if there is an adverse reaction, it can be life-threatening. So if a patient does have an adverse reaction, we're going to jump into work mode and go in and hopefully stop that adverse reaction from happening before it gets any worse and it kind of threaten that patient's life. Side effects are expected, adverse reactions are not. So that's a good way to remember that. If we give a patient a medication and we expect them to have a little bit of nausea or maybe have a headache, that's fine. We don't want to worry about that too much. But if we give a patient a medication and then they go into cardiac arrest, obviously that's going to be an adverse reaction. We don't want that to happen. Nice little chart here demonstrating the two side effects and adverse effects and the differences between them. So a side effect, as I was saying, an effect of a drug or chemical that is in addition to its intended effect, and it can be both therapeutic and harmful. And again, they're usually expected. They generally don't hinder the effect of the drug, so nothing is really going to get bogged down by a side effect. And they're pretty mild usually and pretty self-resolving. You're not going to need to do anything to make sure that the side effect goes away. Adverse effects, they're harmful, undesirable, don't want them. And they're generally harmful and undesirable, as I was just saying. They're not expected. So if an adverse effect happens, you're not going to be ready for it, not expected. But it's always a good idea to be prepared just in case. They can hinder the treatment and lead to more complications. So if a patient has an adverse effect, it can end up bogging down that medication so it's not working as well. And like I was saying, they're more severe and life-threatening. Some common side effects. I'm sure a lot of you have taken a medication and experienced one of, if not, maybe all of these side effects. But drowsiness, dizziness, nausea, headache, rapid heartbeat, diarrhea, dry mouth. Those are all side effects we might see when we give a medication. And if a patient's experiencing those, it's always a good idea to educate those patients on what side effects are and that they'll most of the time resolve on their own. Adverse reactions, again, these are going to be way more serious. So heart attack, liver damage, even death. So if we're getting adverse reactions, we're going to want to jump in and hopefully put a stop to them before they can get any worse. Medication interactions. So medications can interact with each other. It can be negative. So it's always a good idea to have a history and know what medications your patients are taking. A good example of that is nitroglycerin and ED medications. As I was saying, ED medications dilate the blood vessels on their own. So if we go ahead and give another medication on top of that that's going to dilate their blood vessels as well, it's going to lead to some bad things. And that patient's blood pressure is going to be super low. Some examples of this: drugs and alcohol usually do not interact well with each other, but a lot of people still don't seem to understand that. And then ibuprofen and blood thinners, as I was saying earlier, don't interact well with each other. So it's always a good idea to know what medications our patients are taking before we give them one of our own. Documentation. As I was saying, documentation is so important so that everyone knows what you gave, what time you gave it, how much you gave, who you gave it to. So it's important to correctly document what drugs you're giving. You want to make sure you have the time, the dose, the route. A lot of the new charting softwares will take the time down automatically for you. But if you're going back and doing your chart later, it's always a good idea to put in the correct time. So it's always a good idea to write down what time you gave the medication. And if you didn't document it, it didn't happen. So if it's not in your chart, in the eyes of whoever's reading that chart, it did not happen because they weren't there and you were. So if you didn't document something and it ends up going to court in the eyes of the court, you never gave that medication, even though you know you did. So it's always important to document. So here's a picture of some charting software. This may look a little outdated, but it's still a good picture of what charting software can look like. So a lot of them are going to have the tabs at the top. When we're giving medications, the one we're going to be worried about is interventions up here. You're going to click on that button, and when you click on that, a little plus sign will come up down here, almost like this piece of paper with a plus sign. You're going to click on that, and then it'll have a list of medications that you can give there. So you'll click on the medication. We'll say you gave aspirin. You're going to click on aspirin, and then it'll come up over here. Well, it'll ask what dose you took, or what dose you gave, sorry, and also the route, and then the time will get filled in automatically from up here. But if you're going back and doing your chart later, you're going to write down that time and change it later. Special considerations. So, pediatrics we talked about a little bit. If you're giving a pediatric a medication, it's always important to know the weight of that kid. And a lot of times if mom or dad is there, they're going to know what the kid's weight is. If not, the Brasillo tape's a good tool. I've got a picture of that on the next slide for those of you that may not know what that is. Geriatrics, a lot of geriatric patients are going to be taking a lot of different medications. So we want to make sure that we're getting a good history on those patients and we know exactly what they're taking so we can know if anything is going to interact. Pregnant women, there's some medications like we talked about with ibuprofen that pregnant women cannot take because it can be harmful to mom and baby. So we want to make sure that we know if a woman is pregnant or even if it's possible that they're pregnant, because we want to always just be extra careful. Allergies, so obviously we want to take into consideration patients' allergies. If a patient is allergic to a medication, don't give it to them. But if a patient, it's always a good idea if a patient says, I'm allergic to something, to ask what it does when they take it. Because some patients don't understand the difference between an allergy and a side effect. So, if, for example, one time I had a patient that I was giving Benadryl to, and they said, well, I'm allergic to Benadryl. And I said, what happens when you take Benadryl? And they said, well, I get really sleepy. So obviously that's going to be more of a side effect and not really an allergy. Now, if a patient tells you, oh, I break out in hives and my throat swells up, obviously we're not going to give them medication that can do that to them. But if a patient tells you that a side effect happens, it's always good to educate your patients on side effects and how they're different from allergies. And sometimes they might still refuse the medication, and that's okay too. It's ultimately their choice. But if a patient says they're allergic to something and they're really not, it's a good idea to educate them. As I've been repeating throughout this, obtain a history prior to giving meds. You want to make sure we know exactly what these patients are taking, if they've got any conditions. We want to know everything we can about this patient before we give them a med. So here's a picture of a Brasillo tape. I know it's a little blurry, but I'll do my best to explain it. So this is going to all fold out. It's going to fold out into one big straight line. This red arrow up here is going to go at the patient's head, and then whatever their feet match up with when it's all stretched out, we'll say their feet line up to, it's essentially measuring the patient's height. So if their feet line up to, we'll say the blue section, this side over here is going to have medications listed, and this side is going to have the dose already done for you. It's going to have the math already done. So this is a really good tool if you have a pediatric patient. But this is going to have the dose already listed out for you. So this takes the patient's height and how tall they are and matches it up with the average weight for that patient. So obviously, it's always a good idea. It's always better to use their exact weight if mom and dad know, but if they don't know, or if the kid is alone and mom and dad aren't around for whatever reason, this is a good tool to use because this will give you a pretty accurate number. Safety is super important. Obviously, we're dealing with open needles, so we want to make sure that we're doing things correctly and safely. Needle sticks can happen. If you stick yourself with a used needle too, that can spread other diseases, and it may not be good. So we want to make sure we're capping needles correctly. And I'll go over a good technique in the next slide for that. You want to make sure everyone around you is aware of the open needle, so no one is bumping into you, if anyone, or if they bump in behind you and you stab them with a needle. We want to make sure just everyone knows that you have an open needle out. And we want to make sure we're disposing of needles properly. We want to make sure all of our needles are going in sharps containers. Make sure that those are getting thrown away the way they need to be. So, with safety again, a lot of these needles will have kind of a self-capping system almost. So this blue piece gets flicked up and it covers up the needle. It almost like sheaths the needle so that you can't be poked with it. And then once you do that, you want to throw it in the sharps container down here. If you're going to cap a needle, this is the technique that I use. There's a couple different ones out there. But you want to put the cap down on a hard, something stable, something steady. You don't want to put it on like a couch or something because then it could bounce around a little bit or roll. But you want to put it on something stable. And then with one hand, so your other hand's going to be completely out of the equation here. You want to take this hand, put it on the needle, and you just want to scoop up that cap with the needle. And then once you have that cap on the needle, you can push the cap down to hear that click so you know it's sealed. But this is a good idea to prevent needle sticks. So we'll go through a couple scenarios here just to make sure that everyone understands these medications and understands what they do. So the first scenario, we've got a 42-year-old male. He's complaining of chest pain. Patient is sitting at home breathing heavily and says he is having 8 out of 10 chest pain. Patient tells you that he's allergic to penicillin. Patient's vital signs are as follows. So his blood pressure is 132/70. His heart rate's 84. His respiratory rate is 20. And his oxygen is 91%. So what medications should we consider here? So it's important to look at those vitals, make sure everything's good. And then we can think about what medications to give. So in this situation, with the chest pain, obviously I would get aspirin on board as quickly as possible. We want to make sure that clot isn't getting any bigger, so we want to get aspirin on board quickly. Oxygen, we saw that the patient was breathing heavily, so he's working hard for that oxygen. And he's only at 91%, so it's a little low, so I would give him some oxygen. I'd probably give him some high-flow oxygen just because he's working really hard to breathe, and his heart is working harder than it should. Nitroglycerin, this patient is having a cardiac event, so we want to give them nitroglycerin for that chest pain to hopefully make that a little bit better. And as we see, their blood pressure is within the limits for nitroglycerin, so we can go ahead and give that. As long as we ask the patient if he takes any erectile dysfunction medications. We want to make sure we're asking that before we give nitro. So the second one, 25-year-old female is found at home laying in bed with a chief complaint of not feeling right. Patient tells you that she's been feeling funny for a little while now and is not sure what is going on. Patient also tells you she has a history of diabetes. Patient says that her last meal was dinner last night, and the patient's vitals are as follows. So blood pressure is 114/76. Her heart rate is 96. Her respiratory rate is 16. Her oxygen saturation is 95%, and her blood glucose is 43. So which medications should be considered? So again, we want to look at the vitals. We've got a little history here. We know that this patient has a history of diabetes. So for this one, the only medication I'd consider is oral glucose. So we see that that patient's blood glucose is 43. That's too low. We know she's got a history of diabetes. She says that her last meal was dinner last night. So that was probably a little while ago. So her sugar's probably low. That's why she's not feeling right. So we'll go ahead and give her a little bit of oral glucose. And after she gets that, she should be feeling back to normal. So the last scenario here. Patient's a 7-year-old male sitting on a park bench in obvious distress. Patient's audibly wheezing and is breathing rapidly. You notice a mark that appears to be some kind of insect sting or bite. Child is able to tell you that he is allergic to bees. Patient also complains of itching skin. Patient's vitals are as follows. Blood pressure is 110/70. Heart rate is 114. Respiratory rate is 22. His oxygen is 92%. Which medications should be considered? So for this one, we know that the kid has a bee allergy, and we notice that something that could be a bee sting. So we're going to want to give oxygen first. That patient's oxygen is low, so we want to make sure we're getting oxygen on board, and he's wheezing and breathing rapidly. So I would go with some high-flow oxygen because he's working really hard to breathe. So we want to get that oxygen up a little bit. Epinephrine I would consider. I would definitely give him epinephrine. We've got, clearly he's allergic to bees. He tells you that. And he's got some kind of bee sting. Whether or not this kid has an EpiPen, if he knows he's allergic to bees, he probably does, or mom does. So we want to go ahead and help that patient administer his EpiPen. If not, it's no big deal. We can draw up our own Epi and give him that way. Albuterol, I would maybe consider albuterol, and says he's wheezing here. If we give the patient Epi, albuterol would not be high on my list, I'll say that. But if we give the patient Epi and the wheezing does not subside, I might go ahead with some albuterol after that. But after we give the patient Epi, I would wait a little bit and then listen to lung sounds. If the wheezing is still there, I might go ahead with some albuterol. If not, no need to worry about it. So that's something I might consider. A couple resources here for you before we wrap up. So this website here is going to be a drug interaction checker, so you can type in the drug or the couple drugs and see if they interact with each other. It's a really good tool to use. The NCEMS drug list, that's going to be really helpful. That's got all the drugs, all their doses, all their indications, contraindications, everything. So that's really helpful. Your protocol, always a good idea to look at your local protocol. You want to make sure that you're following that before you follow any state protocol. So it's always a good idea to check that. Hippocrates is a good app. I have that on my phone. It's a good medication reference. So if you hear a patient's taking a medication and you don't know what it is, you can look it up on this app and it'll tell you exactly what it does. It's a really helpful tool. Google is also a good resource. If, again, like I was saying, if a patient gives you a medication or a nursing home gives you a list of medications and you don't know what in the world these patients are taking, it's always a good idea to look them up. You want to know what they do. It's better to look them up than just guess what they do. I'll say that. So that's going to be it for this. Thank you everyone for listening. I know it was a little long, but I'm glad that everyone paid attention. Thankful for everyone listening, and I hope everyone learned a little something.